Hi Mom, we're back on YouTube again, and we're going to discuss the three tissues that have to change. What is structural correction? Structural correction is a change in the soft tissues of the body, not just the spine itself, but also the entire body, so that the patient can take care of themselves without the aid of the doctor. The bones really aren't much of the problem. It's the stuff that's in between the bones. And those tissues are divided into three categories. A triangle is a delta, which means change. We have white tissue, red tissue, and neural tissue. Those are the three things that have to change. And if you don't change them, or if you don't change them enough, and this is how I gauge every kind of theory, principle, concept, technique, idea, pontification, I judge it by this standard. If it doesn't change these three things, it's not sustainable by the patient without the doctor. White tissue is the fiber. The fiber of the body is tropocollagen or collagen. It's a coiled protein, a single helix. That helix has to change shape. Since it's a coil, some of it has to get shorter and some of it has to get longer. The stuff that has to get shorter, that's easy. It doesn't take any energy. It goes through a process called adaptive shortening. It's much like when you get in a car and drive for a couple hours and you get out and your knees are very stiff. That's because you've had them in the bent position for a long period of time. Those fibers have adapted to their new position and they've folded up on themselves. And it takes energy to elongate them. We want to go through a process called adaptive elongation, which is what orthodontists do. It takes a lot of vitamin T, or time. We want to open these fibers evenly without tearing them. Why? We're going to go over that in just a second. That's adaptive elongation. There's another way called plastic deformation. Permanent plastic deformation is a better term for it. It's like overstretching a spring. Once you've done that, it's changed. You've created a weak area. We normally talk about the degeneration that happens as a result of that because it becomes very sloppy and then the system starts to lock that slop down. The thing that we've learned since then in Spine 1999, the article won the Volvo Award that year. Very interesting. It says that when you get instability, it creates a sloppy joint and the mechanoreceptors that monitor that joint become desensitized. Because of that desensitization, the nerves that go up to the cerebellum and brainstem that monitor the posture and the function of those muscles in that area, they shut down, which in turn shuts down the central governing system in the brainstem and therefore shuts down the muscles that are at that level. So that segment becomes bare. Those muscles that are in tight around the spine quit working. That leads to future injury, not just because of instability, but injury because the protective mechanisms, the protective reflexes no longer function. So there's a very big reason not to use permanent plastic deformation, especially we deal with difficult cases here, and especially scoliosis. You do not want to add instability to an already stable situation. So we're working to get adaptive elongation to happen over time. So we're changing the white tissue. In a scoliosis patient, when they're twisted and contorted, their entire body, the fiber has changed, the thoracolumbar fascia, there's a remigration of those fibers, and as we start to unwind them and change them, those fibers have to remigrate. Even the pia mater that's around the cord, the spinal cord itself and brainstem, has to remigrate those fibers, the pia intima, in all of it. So we're counting on a change within the white tissue, and that takes time. Red tissue It's called red tissue because it has blood, whereas white tissue doesn't, therefore it's white. The red tissue we look at as muscles, but particularly the muscles that have to be affected are type 1 slow twitch, postural muscle fibers. Now there's a lot of different styles and theories on how to work those work muscles and do rehab. If it's not working with type 1 slow twitch, it's actually creating new problems that you didn't have. And there are 3 articles in Spine since 2006 that talk about cortical-based, fast twitch, surface muscles, that kind of rehab, like the therapies that tend to be used in physical therapy offices, chiropractic offices, where you're using sets and reps and where you're using your cortex to do it rather than your brainstem, they are literally creating chronic back problems. Here's what they say in the articles. The problem is that it creates a new neuromuscular recruitment pattern that persists after the pain. That the function of the system is now relegated to the voluntary system, and that's not set up to do that job. It doesn't even have the muscles to do it. It's using surface muscles. So that's why we want to use type 1 slow twitch muscle fibers, and that's what we can concern ourselves with, particularly with the weighting system. We're forcing the nervous system to use the slow twitch muscle fibers. Then we're using the neural, we're talking about the brainstem, which includes the cerebellum, because the cerebellum is actually a part of the pons, which is a part of the brainstem, and the alpha 2 nervous system. That's what we're using, rather than the A alpha nervous system or 1A alpha nervous system that is for voluntary system. So we're going to be concerned with using the brainstem, and that's why the weighting system works so well. Everything that we do is concerned with changing these systems to the point where the patient can maintain themselves on their own without our help. Much like orthodontics, when the orthodontist is done, he takes the braces off and gives you, what does he give you?
A retainer.
A retainer, very good, which you're to wear about once a week for the rest of your life, which nobody ever does. But we teach you from day one that as we're caring for you, when we are done, we're going to give you a retainer, which is the weights, the molding, the isometrics, and you're going to do them at once a week for the rest of your life. When you're dead, you don't have to do it anymore. Is that clear? That's how we say it. So, this is how we change the structure and to create a true structural correction. The key at the top, we use the acronym ARC 3D. Active reflexive correction in 3 dimensions. And that is the weighting system. We use the weighting system to change the patient, first in the sagittal plane, which is looking at the patient from the side, putting those curved systems back. That's the most important. Then we change the coronal plane. Then we're going to change the transverse plane. And then we've created a 3-dimensional system, weighting system, that will maintain them after we're done. And that's the actual ARC 3D. We've created a 3-dimensional weighting system that orients the individual to gravity, gets their head over the center of their body in 3 dimensions. Any questions? Very good.